more. Next week will be case discussion number 3 on harms and benefits presented by Dr. Ahrens. And I'll give you the information for those of you who have an opportunity to read ahead. If you want to make a note, it's Chapter 3, Are Research Benefits and Harms Fairly Distributed? And that's pages 71 to 75. And he'll be discussing case number 18, on rotavirus vaccine, page 76 to 77. And if you've been following the series, as you know, we're using the casebook on ethical issues in international health research, and you've all got access to that online. So today we're talking about Chapter 2, Issues in Study Design, and the authors raised 2 central issues. One, they ask, is it a matter of ethical concern how well a research project is designed in scientific terms? So I would guess that many of you have either posed this question yourself or been asked it. And as you probably know, there's a lot of disagreement among investigators, REC members, and others about how to answer that question. And then secondly, is the REC or IRB the right body to judge the scientific merits of a project? We're going to be talking about case number 15, Twin Registry Genetics, which although it deals with genetics, it also deals with mental illness and things that I think are particularly of interest in the Caribbean. So I think, as we'll see shortly, it's a very useful case to look at. It's actually much more complex than it seems at first glance. Before we get into talking about the chapter and the case, I want to remind you about Webinar 2 by Carla Sands. And she made the point that even research asking socially valuable questions can be designed or conducted poorly. And this is important because, first of all, we need to think about what we mean when we talk about socially valuable. Is it a research question that's going to lead to improvements in health, for example? And it's also an important question because basically the way we design our study, if it's done poorly, inadequately, if the methodology is inadequate, we're going to have a problem getting meaningful data to the question we're asking. Carla reminded us of some highlights about study design. So subject selection should not be biased. It should be based on scientific criteria. The risks to participants and communities must be reasonable and minimized. The benefits, again, to participants and communities must be maximized. And there needs to be participant understanding of a whole range of things involving the study and themselves, their role in it. And I want to emphasize here that that participant understanding is really contingent on the investigator's understanding and also the investigator's integrity. So therefore, for an REC member to review the ethics of a study, they really need to understand very clearly what is the research question or hypothesis, what is the method or methods that we're using to answer it, and will that method really provide us with a meaningful answer, meaningful and reliable and valid. Understanding the risks of wrongs and harms, and definitely understanding the distinction between wrongs and harms. I think an emphasis should be on the probable benefits rather than the possible benefits. Obviously, alternatives to the study design or to the participants' roles in it. And while the participants don't have to understand therapeutic misconception, certainly investigators and REC members do need to understand it so that they can guard against it. Carla in Webinar 2 also mentioned the special protections, the need for special protections for vulnerable groups. And I want to emphasize that this is really important for REC members and consideration because it's not clear, there's disagreement as to what constitutes a vulnerable group, and there's also disagreement about what are adequate protections for a particular group in a particular study or circumstance. So let's turn to Chapter 2 now, and the first section in Chapter 2 of our casebook talks about connecting research design to ethics. So I want to make the point that, that research occurs in a social context. The authors make this point, and what that means is it's not just something we do in a lab or in a clinic. There are societal factors, there are economic, political, social, cultural, religious, and other factors that influence what our research priorities and goals are, and they also influence the resources that we have available to us to design and conduct and analyze and act on the study, act on the results, that is. So whether we like it or not, money is one of the things that does affect study design. It affects what we prioritize, what we choose to study, the way we design it because of the resources that are available. For various reasons, it affects whether and where we publish the results. And for example, in terms of private investment, certainly it affects pharmaceuticals want to invest in studying diseases that afflict many people, like heart disease or diabetes, because there's a huge market for that, as compared to something like the tragic ALS example, where it's a tragic disease but a very small market. So this poses a little bit of a conflict of interest, sometimes maybe a big bit of conflict of interest, and it challenges researchers' objectivity so that this can affect the way they prioritize their research goals and questions, the way they design their studies, the way they conduct them, their objectivity with respect to peer review of others' work in all sorts of, not just for publication, but for grants. And also, it challenges their ability to earn public trust, to earn and maintain public trust. And this is really critical. It's an area that I think, as investigators in medical research or any other type of research, that we really all need to do better at earning and maintaining public support and trust in our work. So research, of course, is very valuable to society, and we use the data to help solve problems in all sorts of realms, from medicine to agriculture to policy, all sorts of areas. And so our casebook poses the question of when, how, and why researchers might be tempted to violate ethical standards. And I would just ask you to maybe type in some comments to answer any of those questions if you have thoughts about that. When, how, why might researchers be tempted to violate ethical standards? What sort of conditions? Okay, to publish their work for financial gain, absolutely. Two excellent examples. When it's more costly to be ethical, absolutely, and sometimes there are situations where that becomes the case. When a functional IRB does not exist, that's also very good, very, very true, because in so many low and middle income countries, IRBs or RACs do not exist, or they exist and they don't adhere to international standards in terms of their makeup or their frequency of meetings. Pressures to publish, absolutely. So you're coming up with great examples. There are a lot of reasons why we're tempted, including the financial conflicts of interest. I see someone's added personal biases, absolutely. A similar question is whether researchers have ethical responsibilities over and above those of ordinary people. Another one, lack of ethical training, responding to the first question. I absolutely agree, and we definitely hope that this webinar series is helping to improve knowledge of REC members and investigators and others in the region. So do researchers have ethical responsibilities over and above those of ordinary people? And this is a really interesting question. I think that in my experience, discussions often start out from a view that they don't, but generally then a discussion over time evolves and people begin to agree that, yeah, maybe they do. But I want to move on with this webinar, so we won't get into that just now. Our chapter 2 makes the point about research collaborations with private industry, and that this is something that's becoming more prominent, more prevalent today in terms of research, and that it's a conflict of interest in that academic values such as transparency, objectivity, clash with business interests, making a profit. So conflicts of interest certainly compromise things like peer review, but they even compromise the way we design and conduct our studies and the way we report them. And this is a problem, according to our authors, and I agree, because when we compromise our study design or the way we conduct and report the findings, our results are not reliable. They're less meaningful and less relevant, and yet less useful. And you can even go as far as to say that they may harm or even kill people, they waste money and resources, and they may be the foundation of misguided laws and policies. So it's very important that we recognize when there are conflicts of interest, and we recognize the temptations to violate ethical standards and minimize them. So the next section in the chapter asks, who should assess the science in the context of ethics review? And this brings us really directly back to the central issue that we raised on one of the first slides. Is it good science? In other words, will the research question being asked be answered adequately using the study design that's proposed? Can the results be produced equally well by exposing the participants to less harm? And are the results worth the burden and risk that we're creating for participants and perhaps others? So these are important considerations for REC members, but also for investigators when they're designing their studies. Now, the authors ask what alternatives there may be to REC review for assessing whether it's good science, and these three central questions. And they talk a little bit about the various reasons why you might want to go to using a scientific review as well as an ethics review. However, that does become bureaucratic. It can slow things down. It can add other elements of bias and conflicts of interest. So it's an open question, but certainly there are alternatives, and some, for example, some granting agencies will require a scientific review and a separate ethics review, or some ministries of health may require that as well. And then why would we think that a REC or IRB is capable of doing this? And I would say that those that adhere to international guidance for how they're constructed and trained and how they function, those that have the resources to do so as well, really are capable of making these kinds of judgments. And also that they should, in fact, although maybe they're not always, but they should, in fact, be capable of recognizing the need for research and understanding that we don't want to block studies for inadequate reasons. What I perceive an REC member's role as reviewing, and then hopefully if they detect an ethics concern about a study design, an inadequate a study that's inadequate, a design that's inadequate for answering the question that's being posed, then that they, rather than just say no, this is no good, they work with the investigators and explain the concern and encourage the investigators to make the appropriate modifications, so that we don't want RACs to be obstructive inherently. We want to provide guidance and support to ensure that socially valuable research does in fact get conducted ethically and scientifically in the appropriate manners. So then the authors talk a little bit about particular design issues, and they get into placebos. They talk quite a bit about placebos, although we're not going to discuss a placebo trial today. I think it bears mentioning the phrase clinical equipoise. It's a really important concept, although there are some concerns about it in the current day. Placebos are so controversial, as you're all aware, both in research and in clinical practice, and people like to raise questions about placebos. So the authors deal with it, I think, in a very effective way. And the idea about, to quote them actually on clinical equipoise, they say, when an unbiased expert has a genuine uncertainty about whether the new treatment is better than nothing, a placebo, that's called clinical equipoise. And they also quote CIOMS, one of the important international guidance organizations, as saying this: as a general rule, research subjects in the control group of a trial of a diagnostic, therapeutic, or preventive intervention should receive an established effective intervention. So the idea is really that all of the international guidance out there says that, okay, maybe sometimes placebos are acceptable, but they definitely need special precautions, special attention, and special justification to use them. Basically because this concept of clinical equipoise is such that we wouldn't use a placebo if we knew that the other product or drug or test was effective. We wouldn't need to test it. So if we genuinely don't know, then it's okay to make the test. But on the other hand, there are alternatives to placebos. So for example, you can use, instead of a placebo, you can use a similar drug that's already available, or a similar test or intervention. And that's why the guidance is what it is. The chapter also talks about misleading studies and about observational studies, which I think observational studies are very things that we're in the Caribbean pretty use a lot, shall we say. And these are things that, particularly misleading studies, really rely on the integrity of the researcher, hence the little image here of the book, Integrity in Scientific Research. So integrity is really important, as well as the ethics and the scientific validity of the way we construct studies. But moving beyond scientific validity, the chapter then talks, and we're coming down hopefully to the end of talking about the chapter itself and get into some case discussion in a minute. Moving beyond scientific validity, the chapter talks about fairness and about relevance. And so fairness, they're concerned with selection criteria for participants, and they talk about avoiding bias, posing the example of recruiting at a public rather than a private clinic. So sometimes you may have really valuable reasons for doing so, but sometimes you're doing it simply for convenience, or because the public is perhaps is a little bit more less likely to challenge you, more likely to do as they're told, perhaps. I also want to mention something that they mention. The NIH in the United States has been concerned with since the 1990s. Women, particularly of childbearing age, and children have traditionally been treated as vulnerable groups within research, the conduct and review of research. And what this has meant is that all the drugs out there that we all take that are on the market, some of which are very new, really have not been tested in women or children. And so women and children are getting, I would say, or you could look at it, inadequately tested drugs. They don't know the safety or efficacy in their hormonal or metabolic milieus of their bodies, or the dose response, the body size, body mass, these kinds of things. So we don't want to automatically accept exclusion or inclusion criteria that are stated. We really, as an REC member, really want to think about, or an investigator, think about why and whether we ought to be including or excluding particular groups. And that is an ethical concern. Also, then the authors talk about the relevance of the research to a society or a nation. Specifically, they focus in on the research purpose. And I think this is really important in the Caribbean. They use the example of clinical trials in host low and middle income countries that are proposed or conducted or sponsored by wealthy nations. And we all know this has happened, HIV testing, for example, in Africa, many examples. And it's not always a bad thing, but the ethics need to be looked at. And one of the considerations that should always be examined is what's going to happen with the product or outcome. Will it benefit the host community as well as the wealthy country sponsors? So the ethics guidance coming from, again, most of the international documents, Helsinki, FIOMS, etc., would say that to be ethical, research must be relevant to the Okay, excellent. All right, so can I keep you on the phone while I get started and then hang up if it seems to be all right? Okay. There we go. Okay, you're not hearing me at all. Okay. All right, so I'll hang up the phone now? Okay. Hello, welcome back, and I apologize for the disruption. Thank you to Kevin and the PAHO support team in Trinidad. for getting us back on target here. So RECs have a role in assessing the ethics, including the science of research designs and relevance. I'm going to just zip through this slide because we lost a bit of time there, and I really wanted us to get into a discussion of the case. But the point being that we do need to understand very clearly, and in order for us to understand, the investigator also has to understand and be very explicit about the research question and the aim, and the ability of the study design to answer the question, not its ability to answer other questions. Also effects on participants, etc. But some of these are really matters of moral judgment and very much subject to debate, which is why our REC members are intended to talk with each other, to debate, because we change our minds sometimes through this process of deliberation. So, case 15, Twin Registry Genetics. So let me talk you through the first bits, and then I'm going to ask you some questions. My understanding reading through this case is that the question they're asking is this: are common mental disorders caused by genetic or environmental factors? And they're giving us the examples of alcohol dependency and suicidal ideation. So this is an interesting question in and of itself. And my initial thought is, how are you going to answer that? That is not an easy, straightforward question to answer in any very clear-cut yes or no answer. So already my interest is piqued here as to what is it that they're proposing to do. Now the case tells us that promising twin studies research on mental disorders have been done. So that's good. As REC members, then, we might want to know what. And here I was going to ask you to offer some thoughts, what questions you might have just on the simple basis of what they've presented, what the background, what the research question and the background that they've given us here. What questions would you ask? And obviously I've given you a few questions there, but what others would you might ask, or how would you take these further? Everybody hearing me? Is anybody writing? Okay, a couple of you are writing. Yes, 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 you're hearing me. Don't want to answer the question. Okay, so some of the things that they'd want to know. Well, the first thing that I wanted to, okay, we're thinking, sorry, I need to give you more time perhaps. The first thing that I'd want to know, when you tell me that promising twin studies research has been done on this problem, well, what's it shown? And has it clarified anything about the genetic or environmental basis, and how clearly has it done so? To me, that's a really important consideration. Also, we might want to know the implications of the various kinds of findings and the relevance to low and middle income countries if we're proposing to do it in the Caribbean. So let's move a little further into the case then. And now they're telling us it's an example of host and foreign research. It's a collaboration. Okay, good question. Are your studies building on what has been learned already or just repeating? Okay, and so that's coming back to this previous slide. Sorry, I don't know if I guess it's giving me a weird message. I hope everything is coming through still. So that, anyway, that is a very important question. So host and foreign research collaboration. We're examining the rates of suicide or suicidal ideation, alcohol dependency, somatoform disorders among twins in low and middle income countries with high rates of those conditions. Now, the first thing I think of is, okay, suicide, alcohol dependency, these are sensitive areas, to put it mildly. Somatoform disorders, I confess, I had never heard that term before. So I took a look at it, and I now appreciate more than, you know, the case gives us a little footnote to tell us about it. But I actually looked online a little bit, and apparently it is a real problem and a somewhat prevalent problem. There was even a study in Trinidad that about 10% of a particular population attending a clinic had somatoform disorders. So there seems to be relevance, I guess I would say. That's my initial. That's not a conclusive answer. That's my based on my knowledge and experience. Okay, I'm just looking at someone's typed in what type of studies and how strong were the study designs, I guess with respect to the previous slide, and I would agree those are important, very important questions. So you're all on the right track. Okay, so coming again from the study as told to us, as I pulled out the goals, one is to determine the role of genes versus environment. And again, I see that as a problematic goal because you can perhaps provide some insight into those roles, but to conclusively determine the role, I'm not sure that that's very easy to do, if possible at all, in one study. And documenting prevalences, okay, that's often a very useful thing in public health. So that certainly the study can do fairly easily with limited resources as well. So in what ways are these valuable goals? So if you want to write in some answers to that, are they valuable, and if so, in what ways should we be pursuing those? So before we even get into the method, we're thinking about the nature of the study itself. Okay, and as you're thinking or writing, you can also think a little bit about the study participants. Maybe you want to write in some questions or comments about that. I have a few questions I would pose. Okay, your answers or questions, comments are coming in really fast here. I'm scrolling up. Okay, if genes are found to have a larger role, what is proposed? Genetic engineering? Exactly. What is proposed? What's the usefulness of this? And is the information going to be applicable? Could provide new knowledge if it doesn't already exist. Okay, so we want to know more about what knowledge is out there already. It can inform further research and documentation. Yes, I think that we probably all agree with that. Okay, as far as study participants, I think it's interesting. Okay, well, it's clear they're focusing on adults. Okay, that's fair, that's useful. Seems all right. 2,000 twin pairs and 1,000 singles. Sounds like the prevalence of these conditions is already known, has been a comment someone made here. But, you know, perhaps prevalence in different places is useful in terms of controls, interventions, budget. Got more coming in, let's see. I can appreciate including twins as participants given their similarities in genetic makeup, yeah. The value of the goals would be dependent on a number of factors, one being the percentage of the population affected by suicide and alcohol dependency. Absolutely. So one of my concerns about this study participant, the numbers, is what's the statistical significance of these numbers? Why 2,000 and not 200? Why not use 20 twin pairs and 10 singles? So if there is, when we're using this large of a numbers, you want to have a sense of the statistical validity of that. So that's a concern to me that it's not stated here. Also, our exclusion criteria. Why are we excluding the severely mentally ill? Well, that might be an important thing, or the illiterate. There may be reasons, scientifically and ethically defensible reasons for excluding them, but I would like to know more about why. I'm coming back to your questions again. Your goal, yes. And someone's asked, are the twins identical? So, and we're going to see in just a moment that some of them are. So here's the study design. So first of all, recruit and inform participants. I would say that the recruitment process is sort of the part one of the informed consent process. And they haven't told us where they're going to recruit or how, so I think that's something I'd like to know more about. How are you planning to recruit people? How are you going to choose them? Where are you going to find 2,000 twin pairs? Study design also says we're not going to reimburse them, so we're asking for a lot of their time to conduct interviews and questionnaires. We're not telling us how much time, but we're not going to reimburse for time or travel. They're telling us right up front we're not going to provide any care. If we think you need it, we'll refer you to the nearest facility. And I think they said somewhere in there they alluded to national practices for suicidal referrals. Okay, they're going to, and as I kind of talk through the slide, please type in some comments in the interest of time. Let's try to work through as much of your thoughts, questions, and comments as we can. So looking ahead on the slide, if you have questions or comments, please do type them in. So we're going to do interviews and diagnoses. So presumably if we're going to be diagnosing alcohol dependency or suicidal ideation, our interviewers are qualified to do that, right? Well, we can presume that, but really I guess we need to take a good look at who then is going to be doing these interviews and making these diagnoses. We've got a questionnaire about life events. They're telling us they're going to ask things about academic achievement, abuse, neglect, etc. And so that's potentially some sensitive issues, and you might have some questions or comments about that. They're going to do buccal swabs only on the same-sex twins because they want to determine monozygosity or dizygosity. And then they want to inform participants of what they find, those who get the buccal swabs, and then they're going to anonymize the samples. So once the samples are anonymized, in principle, any ethical problems with the samples may go away, but I would say maybe not. So again, put in your questions and comments, and then I'm going to add a few more thoughts to this slide. Why no referral to the nearest facility? Yes, in this instance they've said they will refer to the nearest facility. However, I would say that raises questions about standard of care, because the nearest facility in a low and middle income country is not going to provide the same standard of care as one in a wealthier nation where our host researchers and sponsors are coming from. So that raises some questions. Does the researcher need to detail the process of recruiting participants in their proposals? Well, that's a good question. My answer would be absolutely, because I want to know how you're going to identify and approach people for any study, really. Are you going to do it in a parking lot of people going to the grocery? Are you going to do it in front of a Planned Parenthood clinic, you know, these kinds of things. Who's going to do the recruitment? What are we going to say to participants as we're recruiting? All of those things are important questions for RACs to consider. I would also like to know, if we're doing interviews and questionnaires on what we would all agree are sensitive issues like this, where are these interview questions and where is the questionnaire coming from? Are these standardized instruments that have been used in other situations? Are they modified to be culturally sensitive? Or are they just some questions that this research team put together and felt like asking? This would be an important issue for me. With the Buccal swabs, I don't know much about genetics. I'd like to know why it matters, whether they're monozygous or dizygous twins. And I'd like to know why you would inform them of that information and what it might mean to them as a member of an REC. Those questions come to my mind. I don't know why you would want to do that. Also, even though we've anonymized the samples, or we're told this is going to happen, are they anonymized by country or by region or by community? Because there's always potentially stigmatizing issues that can come out of such information. So let's kind of review where we are, some of the points of concern. So the interview and the questionnaire, they have not told us where, when, or how long, how much time this is going to take, and they're not going to give any reimbursement for people who maybe missed work. They've not really addressed the sensitive nature of the questions, so to me, an REC should be looking at that. An investigator should tell you, we're asking these sensitive questions because here's the reason why we need to know. Here are the safeguards we've put in place so as to not distress our participants or so as to manage their distress if it arises. That's not included anywhere here in this study design that we're aware of. The source of the instruments of the surveys and questionnaires, and in fact I'd like to actually see them attached as appendices so that I could assess for myself the relevance of, you know, as an REC member, I've often seen studies that tell you they're looking at one question, but then one particular thing, and they're doing a fairly innocuous questionnaire, but then the questionnaire has all sorts of demographic information that is makes the participant very identifiable in the Caribbean context. And so some of those questions are not necessary, or the demographics, or should be justified as to why they are. The Buccal swab, I want to know, as I said on the previous slide, I want to know more about why that needs to be done. And then let's think about, as an REC, what are the implications for the individuals who are participants? What are they going to do with the referrals that are given to them? What are they going to do if incidental findings come up? What about privacy? Well, we're anonymizing the info, the genetic info, but what about the rest of the information? How are we protecting the confidentiality and privacy? What about the nearest relative? They talk about contacting the nearest relative if someone is suicidal, and is that really the appropriate thing to do? So there are other concerns that come up as well. Conflicts of interest. You know, we talked a little bit about this at the beginning, but who stands to benefit really at the bottom of the slide? Who stands to benefit and in what ways? So how will the participants benefit? How will the host researchers benefit? How will the host country benefit? And then how does that compare or contrast to benefits to sponsors, particularly private sponsors, and to foreign researchers? These are really important concerns, or should be, for REC members as they're looking at these kinds of studies, looking at any studies really. So then we've only got a few more minutes here, but the cases that the questions that the case poses. So please begin to read and type in some thoughts on this. Is it acceptable to design a study with exclusion criteria that leave out the illiterate and the severely ill, groups who could be most in need, and thinking about, vulnerable, marginalized groups? You might ask yourself, well, are these vulnerable groups? Are they marginalized? Does the study really exclude them? And is that a problem? Okay, and I'll move on to the next question as well. So you can perhaps think about and respond to that one. As some of the research subjects might have mental illnesses detected for the first time during the interview, is it sufficient for the researchers to refer patients to a service without assurance that they'll be properly treated and without promise of future follow-up? And I can see that some of you are writing either about the first or the second question, and if you happen to have the questions in front of you, you're welcome to, from the actual case, you're welcome to type in questions, comments, answers to any of the questions they pose, and we'll try and talk about them a little bit. Okay, it looks like some of you are writing, but nothing's coming up, so let's move on to the third question. Are the researchers responsible for following up on the potential impact that the results of this study might have on individuals who have identical twins with severe mental illness? Okay. So, well, it looks like some of you are writing, but I'm not seeing, oh, maybe I'm not scrolling down. Okay, oh my goodness, apologies. This is my first webinar, so it's full of technical challenges. Okay, nearest facility needs to be defined. Very good, I agree. Where would the interviews have been done? Yes, good question. Need to know that the setting is conducive to the nature of the study regarding privacy, confidentiality, etc. Absolutely, and they haven't told us that at all. To add to Roanna's question, what about participant privacy and confidentiality? That was not addressed. Absolutely, it really was not addressed at all. And what's very interesting to me as an REC member is that we'll often get studies that say things like, we will protect privacy and confidentiality, data will be kept password protected, and that really to me doesn't fully address the question of how you're going to do it, especially for things that are of a sensitive nature like that. Not at all. How we define these terms is very important as well. These persons may be the most in need of follow-up attention, absolutely, these groups that were mentioned. There may be more illiterate persons in low and middle income countries, so they should be included. Okay, that's an interesting question about illiteracy levels. No participants may not follow through on the referrals. That's absolutely something that I'm aware of in the region here, that even in healthcare settings, patients go in for treatment and don't follow up on referrals. Exclusion groups are justifiable only if the possible risk of the research outweighs the benefits to the participants. I mean, there's often scientific reasons as well why you would exclude groups, as well as ethical reasons, I guess. But certainly we need to be cautious, as per some of our earlier slides and the international guidance, we need to be cautious that we do have special protections for vulnerable groups and individuals. The question being, do the mentally ill or illiterate constitute vulnerable groups or individuals, and to what extent does that weigh in this particular case discussion? I don't have an answer for you, but I think that's a very important point to follow up on that was made there. It's like screening. Don't do it if you are not willing to ensure adequate follow-up. The researcher doing the initial assessment now has a responsibility to assure care and follow-up. That's a really important point, because if the investigator is in fact a healthcare professional, that is absolutely true. And if they're not, I think it's certainly debatable as to what extent it's true. I would agree that that's an important thing to consider. I believe referral of patients to appropriate service is sufficient, okay. And I'm sure that I suppose it would be debatable again in terms of what services are available and who's providing them, and there would be disagreement probably among some. To make referrals without assessment of the service is irresponsible. Okay, that's an interesting perspective, especially for foreign researchers and sponsors. Patients should be referred to facilities where the quality of treatment is known to be appropriate and good. Okay, but if you're in some low middle income countries, it may not be up to the standard you'd like. It may be the best the country offers, but not at the standard you'd like. An important ethical consideration is protecting the welfare of participants. Hence, I think the researcher would need to be able to ensure that the participants who need help are provided with adequate care. Good point. We're running really close to time here, but I want to get through all of your comments. The researchers are not responsible for follow-up on potential impact that results of the study might have. That, I would say, is something that an REC would discuss and deliberate about. The participants should be informed that referral to appropriate services will be given if necessary. They should be warned about the potential impacts, and if they agree to participate, that is sufficient. Okay, and that's a reasonable view. I'm sure not everyone would agree with it, and some might feel that it would depend on the circumstances, the specifics of the case. I don't think the researchers are responsible for following up on the potential impact of the results. Perhaps they only have the duty to make public the results. Okay, so another one that agrees with the previous. Yes, researchers are responsible following up and plans for remedial intervention, so disagrees with the other two. To facilitate some of the follow-up recommendations, the terms of reference for the researchers must be clear. Good point, and that's part of what the REC does. First studies in research areas are different from others, correct? Different considerations. What if this is an early study that will enable programs to be developed to assist with caring for these persons? And in principle, that's what we're assuming is the case. Counseling is needed with a referral. Patients still retain the choice to attend a referral or not. So thank you so much for all these wonderful comments. It's 11 o'clock. I'm going to just flip through the last 2 or 3 slides and end 2 or 3 minutes late for those of you who care to stick around. So considerations when designing studies that I think are really important, not just for the investigators but for the RECs. can the method being used answer the question? Who is at risk of wronged? Who will benefit, and to what extent, again, the host versus the private or foreign countries and investigators? Can we reduce the risks? Can we increase the benefits? What societal influences are in play in terms of vulnerabilities and marginalized groups and bias? What conflicts of interests exist? Integrity of the collaborators and the investigators? Treatments or other benefits. Treatments in particular raise issues. And again, REC members must be knowledgeable enough to ask and demand these answers to these kinds of questions. And in principle, that's asking a lot. But in principle, too, that's what we're expected to do. That's what we agree to do on serving an IRC or REC or IRB. It's a lot of work. It takes a lot of reading and a lot of reading between the lines. So take-home messages, I would say, in agreement with the chapter authors, it is a matter of ethical concern how well a research project is designed in scientific terms. RECs need training, they need resources in order to adequately make the judgments about the ethics and the science. This case, I think, exposes really unique issues that are really important, very subtle, deep issues. I want to very quickly mention the CRE project, the Caribbean Research Ethics Education Initiative, and some of you who've been attending were accepted as trainees in cohort 1, and we're very excited about starting next month. For those of you who are Spanish-speaking, cohort 1 of the Spanish-speaking project is open. You can apply for that, and the email is here for our collaborators there. And we hope that this project, and I want to mention actually Donald Simeon from CARFA is on the advisory board for this project, and Derek Ahrens is also from CARFA, and BSEC is one of the faculty. So it's going to be, at least for the English-speaking part of the English-speaking cohort. So we're really looking forward to it. It's going to be great, and we really look forward to seeing how this webinar series and the CRE project over the next few years will improve research ethics capacity in the region. I see Derek is just putting up a reminder here. Next Wednesday, he's going to be discussing case number 18 on rotavirus. In the case book, that's pages 71 through 75. Really, you could just say 71 through 77, which would include the reading and the case. So I look forward to that, and I want to say again, thank you so much to all of you for your patience with the technical glitches and sticking with me a couple of minutes late. Thanks very much, and good luck as you go out there and enjoy your day. Bye-bye.